Good afternoon, viewers. Welcome to the first edition of VDC Diagnostic Education Webinar Series. So today's speaker is Dr. Vikash Kumar Chaudhury. Dr. Vikash Kumar Chaudhury is medical biochemist at Vijaya Diagnostic Center in Hyderabad. He completed his MD in biochemistry from Guwahati Medical College and Hospital. He is also certified assessor for the National Accreditation Board and for Testing and Calibration Laboratories, which is also known as NABL. He is currently the head of department at Vijaya Diagnostic Center Limited. Now, let me introduce Dr. Vikas. So I'm handing over to Dr. Vikas.
Good afternoon, everyone. I'm Dr. Bikash Chaudhury, Head of the Department of Biochemistry at Vijaya Diagnostic Center. First of all, I welcome you to this first edition of the Vijaya Diagnostic Center webinar series. This is the first of the many that will follow in the coming weeks. Now, each webinar will consist of a brief presentation addressing the webinar topic that will be further complemented by a question and answer session where you are greatly encouraged to participate, share your opinion and experiences, and to ask your questions. Today, I shall be talking briefly on a subject that is undergoing intense study and is of a broad and current interest, that is neutralizing antibody test to the SARS-CoV-2 virus. Now, a brief outline of today's webinar, what we are going to cover in this webinar. First of all, we'll have a brief overview of the SARS-CoV-2 virus and general about immunity. Then the current serological test for SARS-CoV-2 virus, the neutralizing antibodies and its importance as of now, and what are the serological tests that we're doing in our organization and commencement of these neutralizing antibody tests. And finally, we'll summarize with a take-home message. Now, if we look at the SARS-CoV-2 virus, the coronaviruses, they belong to Coronaviridae family in the Nidovirales order. Coronaviruses are enveloped viruses, minute in size, about 65 to 125 nanometer in diameter, and contain a single-stranded RNA as nucleic acid material, say size ranging from about 26 to 32 kilobase pairs in length. Now, if we look at the coronavirus, structural proteins, first of all, we have the nucleic acid proteins, which bound to RNA genome to make up the nucleic acid. Secondly, we have the spike proteins, which are critical for binding of host cell receptor to facilitate entry of host cell. Envelope protein that interacts with the membrane protein to form viral envelope. Membrane proteins, M proteins, which are central organizer of co-virus assembly, which determines the shape of the viral envelope. Now, things to be noted here is that some of these coronaviruses do not have the full ensemble of structural proteins to make virions, highlighting that certain proteins may be dispensable or compensated by the function of non-structural proteins. Now, if we look at the emergence of coronaviruses, now coronaviruses are a large family of viruses that are known to cause illnesses ranging from the common cold to more severe disease such as Middle Eastern Respiratory System or MERS and SARS, that is severe acute respiratory syndrome. Now, 2019 coronavirus, the COVID-19, was identified in Wuhan, China. This is a new coronavirus that has not been previously identified in humans. Now, if we talk a little bit about immunity, now in simple terms, immunity is the ability to resist a disease or an infection. Now, immunity to this viral infection is a combined outcome of both cellular and humoral antibody immune response. While this cellular immune response is often difficult to measure, antibody production serves as a hallmark of humoral immune response. Now, if we look at the timing of the antibody response to SARS-CoV-2, the new viruses, if it enters the host cell, there would be no pre-existing antibodies or immunity. We are still learning about our immune response to SARS-2. Now, many develop antibodies 1 to 2 weeks after the symptoms. Now, due to this delay in seroconversion, antibodies do not play a routine role in diagnosis. Now, greater than 95% of the patients are antibody positive only after about 2 weeks. So, this is because some patients may not seroconvert, some immunostatus because of the immunostatus, or it may be because of acid dependent or severity of illness. Now, IgG and IgM, these are the two mainstays of antibodies that are detected in the body. Now, IgM, it declines about 5 to 7 weeks post onset, whereas IgG, it remains positive for more than 10 weeks post onset. Now, this is still ongoing because earlier we thought it would stay only for 3 months. Then the recent studies states that this IgG antibodies may be present in the body for more than 8 to 10 months. The studies are still ongoing. Now, as far as serological tests for SARS-CoV-2 are concerned, there are over 200 commercially available serological tests for anti-SARS-CoV-2 antibody detection that are present worldwide right now. But because of the pandemic hype and the status right now, there are more antibody tests for SARS-CoV-2 than for any other infectious diseases. Now, variation in SARS-CoV-2 serological test designs. First of all, if we talk about the format, there are different kind of formats such as the lateral flow assay, enzyme immunosorbent assay, chemiluminescent immunoassays. Then if we talk of the specimen type, it could be serum, plasma, finger stick, venous whole blood, lateral flow assay, and the immunoglobulins or antibodies that are detected. They are IgM, IgG, IgA, total antibodies, but CDC, I'm sorry, okay, now we go back one more. Okay, CDC at present, it says that there's no advantages of this IgG, IgM or IgG total antibodies, but testing for IgA is definitely not recommended. Now, to detect the antibodies, the antigens used are S1, S2 spike protein, the receptor binding domain, and the nucleocapsid. Okay, next slide, please. Now, let's talk about a little bit about neutralizing antibodies. What are exactly these neutralizing antibodies? Now, neutralizing antibodies is a subset antibody that inhibit viral replication and represents a major mechanism of humoral immunity against viral infection. The effective function of neutralizing antibody is mainly mediated by the blocking of the interaction between the virus and its host cells, resulting in the inhibition of viral entry to the cells, thus prevents viral infection. Now, because of this mechanism of action, it is not surprising that most neutralizing antibodies are against viral surface proteins. Now, as of now, the question arises, how much do we know about this neutralizing antibodies to SARS-CoV-2? Now, what we know so far, that the virus causing COVID-19 or SARS-CoV-2 uses the spike protein to bind to the receptor of the host cell to trigger cell entry and infection. S protein consists of S1 and S2 subunits, and S1 interacts with the host cell via the receptor binding domain. The monoclonal antibodies to S1 protein that exhibit neutralizing antibodies are being developed as a potential therapeutic to COVID-19. Neutralizing antibodies to the S proteins are the key active ingredients of convalescent plasma used to treat severe COVID-19 patients. In addition, almost all the COVID-19 vaccines currently under development target the S protein with the goal as to induce neutralizing S antibodies. A preliminary vaccine showed a correlation between neutralizing antibody titers with protective efficacy in animal models. Now, this is an illustration of how the antibodies that are developed, how they bind to the different proteins of the virus. Now, as you can notice that these antibodies, they bind to different proteins, or we can say the antigens of the virus. Some did bind to the neutralizing antibody, that is spike 1 protein, whereas the others, they bind to other kind of antigens. Next. Now, after all these observations, it suggests that S protein is a primary target for neutralizing antibodies against SARS-CoV-2, and anti-S neutralizing antibodies play a key role in COVID-19 immunity. Now, role of neutralizing antibodies in protective immunity. First of all, we need to understand that protective immunity is multifaceted. Antibodies, just as we talked about right now, can be neutralized, binding or neutralizing. Now, binding or non-neutralizing antibodies produced at high levels but are unable to independently prevent infections. Binding it, what it does is only binds and flags pathogens as invaders, and they can be a good marker of prior infection. In contrast, the neutralizing antibodies, they bind to the virus, leading to the loss of infectivity and blocking the viral entry into the host cells. And thus neutralizing antibodies, they function independent of other immune system components. Now, testing for these neutralizing antibodies was very challenging, especially to this COVID-19 virus, till about 3 to 4 months back. But since then, there are a lot of multinational companies. They have developed these assays, which are currently being used all over the world. Now, for a good assay to develop, normally takes quite a while. But because of the pandemic status right now, the US FDA has given emergency use authorization first to certain multinational companies to have their assays run in the laboratories for the detection of these antibodies. As in the USA, FDA is the authority. Even in India, the local authorities have approved some of these assays, which we are currently doing. Now, most important is once we have run the test and the assays, now there is data being generated and there are results that are made. But the most important is how are these results interpreted, or what do we do with the data being generated? Normally, you will either get a negative or a non-reactive or a positive or a reactive results. Now, what do these results mean? Now, negative results, what it means is that likely there'll be no prior infection or exposure to the virus. Now, it could also be negative in individuals who have tested too soon following infection, or in immunosuppressed patients, which may be negative. Now, small percentage of individuals may not seroconvert. In fact, they may not develop antibody titers. Now, as far as the positive results are concerned, it suggests recent or past infection and may be impacted by the local or regional prevalence. But more important, what the positive results do not tell us. It does not tell us when the patient was infected, whether the patients are shedding viruses live or dead, or whether the patients or individuals are protected against reinfection. Now, this I would like to emphasize that positive results does not mean that you are protected for a long time or you may not get reinfected. So in other words, we cannot use positive decisions regarding adherence to social distancing, recommendations, use of personal protective equipment. So at the end, I would like to summarize what we have so far talked about. We talked a little bit about the virus, the immunity, what are the serological tests that are there for COVID-19 antibody tests, and what is neutralizing antibody in particular, and what is the relevance and the importance of the neutralizing antibodies. So at the end, if I were to summarize regarding the serological test or the antibody test, so the uses of these serological tests for SARS-CoV-2, first of all, the diagnosis. Now, for diagnosis, there's very limited utility for the very fact that these antibodies, first of all, they develop late, the seroconversion is late, but they can be offered as an adjunct for those who present late or have suspected false negative upper respiratory samples, and the lowest respiratory samples cannot be collected. So it can only be as an adjunct test for diagnosis. Secondly, for epidemiological studies, yes, it may be useful. The assay, provided the assay has adequate specificity, that is greater than 99.5%, and it can be used to screen high pretest probability population, such as in serosurveillance. The third, can it identify convalescent plasma donors? Definitely yes. If you go above a certain cutoff of titer, we can definitely detect whether this patient or this recovered person can donate plasma or not. And lastly, can it evaluate the immune response to vaccines? Yes, it can do, because as I mentioned earlier, most of these vaccines are targeted against the S1 spike protein to induce antibodies against it. So definitely it can be used to evaluate the immune response to vaccines too. Now, at last, I would like to just quickly touch this topic of immunity certificate or immunity passport, as a lot of people have been asking. Now, some have asked if the presence of antibodies to the virus that caused COVID-19 could serve as a basis of immunity certificate to enable individuals to travel or return to work. Now, there has been a lot of talk of it in the past few months, to the point that there has also been a suggestion of putting an additional page in the passports to allow individuals to freely move between countries. Now, all these assumptions of immunity certificate or immunity passport, it rests on the as yet unproven assumption that the infection provides long-term protection against reinfection. Now, antibody-mediated immunity is not yet sufficiently understood to offer any guarantee of protection against reinfection. So, positive antibody test cannot be used to exempt anyone from public health measures in their community or at work, or to group people in settings such as schools, dormitories, or even correctional facilities. So, in other words, there is currently insufficient information to conclude whether the people who have recovered from COVID-19 and have antibodies are protected from a second time. So this is where I would end my brief talk about the COVID antibody test, specifically the neutralizing antibody test. And I would like right now to encourage you to ask your questions, if there are any, which I will try to clarify whatever questions you have as of now.
Yeah, Dr. Bikash.
Okay, thank you. I see that some of the questions that have come in of late. Now, I would like to first answer a question by Dr. Pritibala Take. What is the cutoff for plasma donors? Now, Just to inform you, since last year, I myself have donated plasma on two separate occasions. And both the occasions that the institute I went to give my plasma, they had different instruments and they had different cutoff values. The first one had 6 as the cutoff, whereas the other one had 12. And recently they are being revised. Now, where in my organization, for the neutralizing antibodies, for someone to be eligible to donate plasma, the cutoff is 4.8. So what I'm trying to say is that since these multinational companies have developed their assays differently based on different methods, so the cutoffs are different for different instruments and different companies. So it would be a good idea to know what is the cutoff for that organization and for which instrument they are performing the test on. Okay, we have one other question from Shantakumar. Why should someone go for an antibody test? Okay, this is a very good question. Why should someone go for an antibody test? Now, like I explained in a couple of slides earlier, that the antibodies tell you two very facts, that whether you have had the infection or not, that is the first thing. And the second thing, if you've had, then whether it provides you with some kind of immunity. And the third most important, which I feel is relevant in today's thing, is that, like I said, most of the vaccines that have been developed, they're developed against the spike 1 neutralizing antibody. Now, whether once you have taken your vaccines, now you need to be sure whether it's effective or not. So this is where the role of the neutralizing antibody test comes in. So it tells you whether the vaccines that you have taken have induced enough antibodies to you or in your body or not. So it gives you an idea whether your vaccines that you have taken is effective or not. Okay, we have one more question here. What is the main difference between neutralizing antibodies and the conventional COVID IgG test? Now, let me just explain that before about 2 to 3 months back, we were doing only tests, or IgG test or the antibody test for binding proteins, not specifically for the neutralizing antibodies. Now, what has happened that, like I said, the other antibodies that are produced in effect in response to the virus, they only bind to the virus but do not prevent the virus materials to enter the host cell. Whereas, if we talk about the the neutralizing antibodies, the neutralizing antibodies actually bind to the virus and blocks it from entering the cell. In other words, it neutralizes the virus and it provides some degree of protection to the individual. So this is the basic difference between the conventional or binding antibodies and the neutralizing antibodies. There's a question by Mr. Anup Kumar. Won't the past data of positive people inform us of probable time of infection if we map one patient's profile with the others? That is a good question, and there is a lot of studies going on, but we have to understand one thing. For every individual, the response would be different. So let's say there are two individuals who have been infected at the same time, just for hypothesis sake. Let's say they were infected in July last year. Now, one person has a good response, his seroconversion is good, and antibodies are developed quite a lot for that person. Now, for the other person, it is not as much as the other person, and it also drops. The antibody levels, they drop very fast on that other person. So if we measure again the two individuals, one may be still quite high, the other anti levels may be low or even non-reactive. So what happens is we cannot really identify how long back the other person had that infection. There's another question from Mr. Prashanti. Are there kits available to estimate neutralizing antibodies? If so, what are they? Let me just inform you. I'll be very happy to tell you that there are kits that are available to us at present. Most of the good labs are doing it, including Vijaya Diagnostic Center. In fact, we have commenced already doing the neutralizing antibodies, that are the IgG antibodies, last week itself. Okay, there's a question. The infection with the virus will lead to interstitial lung disease in the future. Are you able to detect any markers? Now, so far, as far as the laboratory is concerned, we do not have any markers for the future. Right now, we have only two kind of primary markers or tests. One is to diagnose, and one is for the IgG or the antibodies. Now, to diagnose, the two common methods that I use are RT-PCR and RAT. And for antibodies, we have the other laboratory tests. There are other, of course, supportive tests, as we call them, or adjunct tests like LDH, IL-6, T-dimer. They only help in the prognosis, but not for the diagnosis of the COVID-19 disease. Now, there is one question. During the infection, can we take vaccines? Now, during the course of the active infection, and it is not recommended to take the vaccines. It's only after certain gap after recovery, and that it is recommended to go for the vaccines. Of course, you have to consult your treating physician before going for that. There's a question from Mr. Shiva Rani. Good evening, sir. I'm diabetic, 48 years of age. Is it advisable to take the COVID vaccine? Yes, if you have no other major issues or sensitivity to vaccines, please, I would recommend everyone, not only just for diabetics, but anyone who is eligible to take the vaccine to go and get the vaccine. Okay, there's another question here. It's an interesting one. How long do the neutralizing IgG antibody test is supposed to be reactive after being infected or after being vaccinated? Now, as per the current studies that have been conducted by various institutes and as well as manufacturers, your neutralizing body and IgG should be reactive, or should be, after 1 to 3 weeks after the vaccination shot. But let me again caution you, like I've repeated before or said before, that every individual is different, and this response to these vaccine may be delayed. Some may be a little late, some may be a little earlier, but the consensus is it is usually after about 3 weeks. I think this is the same question that was asked by which I've just answered, is the same question asked by Mr. Devadasu also regarding this. There is another question. What is the suggestive level of IgG for plasma donation? So this is again the same question, is what is the cutoff value? Let me reiterate that for different instruments and different methods, it would be different. In our organization, the instrument and the method that we do, the cutoff is 4.8.